Hello, everyone. Hi there. We're just a little late starting, but thank you for being patient. Thank you. Thank you. And welcome to OB Healthy's Doctor's Lounge. Um, we are just so excited today because I have Dr. Matthew Duncan, who is a psychiatrist. And this brother's bad. So we're going to talk about things that are not usually talked about in the Black community. You know, we are proud people. But sometimes we're just a little too proud. And we got to stop and realize that mental health and mental illness is real, even in our community. So many times, a lot of us are suffering in silence, I say. And it's time that we, reach out and see who and how we can help our people. You know what I mean? Not just one person, but we want to try to help each and every one that has a problem with this. So we do what we do. And as usual, the brothers will be coming in. Quite a few of them have committed today to be here. They're making rounds, and we will allow them to come in and introduce them as they come in. All righty. Let me just say what I usually say that we are a group of brothers that are committed. Several things. Number one, to improve health in people of African descent. Number two, to encourage young Black men to go into medicine because it's truly a crisis. Understand that our webinar is every second Saturday of the month at 1 o'clock. And it takes a village to do something like this and make it successful. So please let your church members, your friends, family members know about it because our health is nothing to play with. It is truly the most valuable thing that we own. All righty. If you wanted to see our past webinars, all you have to do is go to OB Healthy and you can hit the YouTube sign or on that doctor's page, there's a little camera and it'll show you all of our past videos. Okay. The most important thing that I can say today is please do not change any aspect of your medical care until you consult your physician. Truly, only your doctor can best care for you from a medical standpoint. Also, as far as the webinars are concerned, please subscribe when you go into YouTube so we can continue to bring this to you. And I would like to thank OB Healthy for allowing us to bring this to you because we use their platform, and without them, we could not do this. All righty. I don't think I missed anything, and we're going to get started. This topic is so important. Well, every topic when you're talking about medicine is important, but this one is, really, really. We all know someone that can use help from a mental standpoint. All right. Dr. Garrison, let's introduce ourselves, please.
Good afternoon, everyone. My name is Jordan Garrison, board certified general surgeon. I specialize in bariatric surgery and venous disorders. My office is actually, it's not in Hackensack anymore. I have taken on a new position, so I'm no longer associated with that company. And I'll be working from home in more of an administrative capacity. So, um, thank you for inviting me. I look forward to hearing Dr. Duncan turn it out, and we'll go from there. Thank you.
All righty, all righty. I am Dr. Well, I'll introduce myself because I want to let Dr. Duncan introduce himself last because he's going to tell us who he is, why he is, and where he is, and all of this mental health and illness as well as wellness is concerned. I'm Dr. Omar Bey. I'm a retired pulmonary critical care doc, and now I'm director of nutritional support for the ICU at Newark Bethesda Medical Center. Dr. Duncan, welcome. And I'll let you know
Yes.
that Dr. Duncan is going to become one of our regulars here. When he can make it, he's going to come on and bestow the knowledge all the time. So we'll be able to ask questions going forward as well. I would like to give a shout out to Dr. Kareem Salam, who's been our psychiatrist for many, many years, but he's gotten so busy and so popular writing books and lecturing and everything that he's not able to do it with us anymore. So I thank you, Dr. Duncan, for filling those big shoes, and we're going to rock and roll. So what I'd like for you to do is I'd like to just step back and tell us who you are, why you came into medicine, why psych is your specialty, you know, and how important it is to, step back and help the people that you help, man. Just give us a rundown. And welcome, welcome, welcome.
Well, thank you. Thank you for having me. Really, really glad to be here. So, first I'll just introduce myself. My name is Matthew Duncan. I am a current uh PGY4 fourth year psychiatry resident, finishing up my last year, and then starting in July, I will be an addiction psychiatry fellow at University of Pennsylvania.
Yeah.
It's a little bit about me. My residency right now is located in Brick, New Jersey. However, it's unique where we rotate at multiple hospitals. So a lot of our training is done in Perth Amboy as well, which is arguably one of the most diverse areas in New Jersey. So we really get to see a lot of different presentations and really see, how culture, ethnicity, etc., really plays into how the attitude towards mental health is. So I think the first thing I'll talk about is my why. Why medicine for me? I did, and full disclosure, I have two great examples. My parents are physicians. They came up here from Trinidad. I'm very proud of my West Indian heritage, but at the same time, one of the things that I have experienced is that mental health is something that you talk to your pastor and nobody else. When you talk about feeling a certain way, you're just supposed to kind of shake it off. You're supposed to shoulder that by yourself. And what I see with regards to medicine overall is really being an advocate for your community, but specifically in psychiatry, the importance of one, addressing the stigma and breaking it, and also letting people understand that it is okay to not be okay and find the proper resources to really address, how you're feeling. Um, also see medicine in a way where we really don't address it until it becomes an issue where you have to go to the ED. Or, it's to the point where instead of a very minor intervention, now it's something so significant, there's a debate of, well, if this was done earlier, we could have addressed this, it would have been fine as compared to, in my specialty, if you're coming to the ED now, we're now talking about whether you should be going into an inpatient unit or not. So I also, I'll talk about background as well. So, born and raised in North Jersey. Uh, my move to medicine was a little bit unique, as in I think I did it kind of backwards. So I say that as in I did go to undergrad, Rutgers Newark. Then I went to graduate school in Harlem at Touro College of Osteopathic Medicine. Uh, took a couple of gap years and actually worked for the North Department of Health as well as Rutgers Medical School in a public health capacity, really addressing different needs. So this would be nutrition, housing, things like medication, or do you have syringes? Do you actually have a blood glucose monitor? These are things that factor into overall health as well. And something that I'd like to talk about a little bit later. Uh, I went to Rowan School of Osteopathic, or Rowan Virtual as it's called now, School of Osteopathic Medicine in South Jersey. And then I started residency, as I was saying, in Brick. So I've had a unique experience where I have had training slash school all over New Jersey. And I can tell you that the way that culture wise, North Jersey, South Jersey, close to Philly, South Jersey, close to Atlantic City, culturally they're very, very different, and the needs are different as well. And with regard to medicine, it's not cookie cutter. You really have to address different areas depending on what is needed, and I think that's really important.
Mhm.
So I think it's a little bit about me.
Excellent, excellent. So, one thing, the way I look at it, And I think all of us physicians, whoever and whatever specialty you are, the mental health or the mental situation of your patient is so important, even into healing whatever the problem is. You gotta be able to relate to the patient. You gotta be able to get them to understand their disease entity. You gotta get them to understand why they should take certain medicines and what the medicine is going to do for them and what's the potential side effect. All of this plays into health and overall health. Um, I'd like to just step back though and just start talking about different aspects. The number one thing I'd like to talk about is depression, you know. Can you give us an idea what depression is, basically? And so that the patients out there or the people out there can understand. And then let's talk about depression because I think that is one of those things that's kind of, you don't even, and how do we identify depression? You don't even know who's depressed. The guy who's laughing all the time may be depressed. You never know. So give us some understanding of how you think about it as a psychiatrist.
So I think that's a great question. And with regards to depression, as you were saying, it presents differently,
Mhm.
right? So one of the first things that you want to talk about is if you're looking at the regular definition, it is several definitions of things like continuing sadness, uh, sleep interruption, issue with regard to sleeping, low energy, feelings of guilt or sadness, and there's a list. Yes. However, the thing about it is that there is also what you call atypical symptoms as well. And a lot of times what ends up happening is that depression can actually be expressed as anger, tiredness, really low frustration as well. So when I look at depression or and really evaluating for it, it's more of, are you still feeling particularly depressed? Or let's not use the word depression. Are you particularly feeling sad or having feelings of guilt or uselessness when things are not terrible? As in, for example, you like playing the guitar. Is it something that you still enjoy? Is it something that you look forward to doing? Or when you are doing that activity, you feel numb or it just doesn't make you feel happy anymore? You just graduated high school or you just graduated college, you graduated with honors, yet you are not in the moment for that accomplishment. You're still feeling particularly sad, you're feeling hopeless, etc. So it's more of, are you still struggling with regard to those feelings of sadness or not feeling adequate when things are okay or really good? That's how I look at it.
Interesting. So I never thought about it that way, but that's true. When life is going normally for you, or things are exciting for you, or you should be excited, you're not excited, or you're not feeling that joy, or you're not, you know what I mean? Boy. So the thing of it is that how do we handle that? I mean, and I'm going to pull this back into our community. How do we in our community handle it? As you stated, a lot of times we do talks to our ministers, but not everybody goes to church. You know what I mean? How do we relate that to our community? Can you give us some understanding?
Sure. So I think that's a really good question in general, because we're talking about resources, right? So if you're identifying other places that are frequented on a Saturday, going to a barbershop, going to a
Mm-hmm.
hair salon, um, one of the most important things that I really ask patients is, I'm like, hey, is there somebody right now that you could identify if you're having a really crappy day that you could talk to that can give you some perspective? Do you feel comfortable enough to be open with regard to how you're feeling? Because one of the big things that I did want to talk about here is really communication and being vulnerable. There's an idea that vulnerability is weakness, especially as men, especially as Black men. Vulnerability is seen as weakness, and therefore we just soldier on without saying anything. You should be able to quote unquote shake it off. And that is problematic because what ends up happening is you see, myself or my colleagues in an ED, and it's so far gone that now we're talking about medication, not feeling comfortable discharging you right now because there's a safety issue. And it's such an extreme for something that really could have been addressed before.
Mhm.
So the the thing that I really want to emphasize, in what I'm talking about today is more of a proactive approach as compared to it being reactive where you're now seeing, psychiatrists in the hospital itself.
Mhm. Yeah, yeah. You hit on something that's so key, man. Is there somebody you can talk to? You know, friend. Most of us brothers, you know what I mean? You get into this macho issue and nothing's bothering you, nothing, I can handle it, don't worry about it, I can handle it, don't worry about it type situation. But that's real. Can you pull back and actually have someone that you can say, whatever problems I have, whatever questions I have, whatever, things I'm dealing with, I can truly sit down and talk with them. Um, is there a way that you can that you give your patients to locate that person, or is there a way that this is it's kind of outside of my realm, so it's even hard for me to kind of structure questions that would be even appropriate for that. Maybe and I know Patrick, you probably get into this with what you do every day. That's for sure because of dealing with cancer and dealing with things like that as far as emotions and questions of even like God, why did this happen to me type thing. You know, so. I just want to know some of the ideas that you think about. Maybe Patrick, you can fill in on some of this.
Hey, Dr. Duncan, Matthew, Pat
Well, first,
Anderson.
Patrick,
Yeah,
introduce yourself.
yeah. To everyone, I'm a regular, sorry I'm a little late. I'm Patrick Anderson. I'm a GYN oncologist. In the St. Barnabas Health System. I work with Dr. Bay, torture Dr. Garrison from time to time.
Oh God.
Um, but to your point, sometimes we have to look at ourselves before we even start to look at our patients and ask ourselves, what resource do we have for support? Dr. Bay, I see him in the ICU all the time. He sees me coming out at OR 2 in the morning and I just look spent or feel terrible. But then, we stop and we talk, and oftentimes in spite of the consults that we ask of each other, we ask each other, how are we doing, how are you doing? And we've made no bones about it. We've discussed issues with our families, we discuss issues with the patients, we've discussed issues, how we can support our own colleagues. So I think for us it starts there. When it comes down to patients, I was going to reserve some of these questions for later on, because oftentimes the folks we're trying to address are the ones that we think are more productive in society, and that's the younger patients, the ones who are in the grind every day. And I was going to have a few questions regarding the geriatric patients, and most of those are the patients that I see with cancer. Um, but with respect to patients, some of the first things I ask them is, who do you live with? Do you have children? Are they close by? Do you have a church that you're a part of? Is there a social network? Because oftentimes, when you go through, this journey, you just need to have a support system. Not necessarily financial, but that emotional support.
Mhm, Excellent, excellent. And I feel you with that, Patrick. I feel you because in the ICU, obviously, we deal with emotions, serious emotions like you do with cancer. Dr. Duncan, give me an idea, what are the most common, mental illness or mental problems that you see in the Black community? Or in general, and just in people general. Let's not just
So
pigeon.
the first thing I'll talk about is trauma.
Mm,
Trauma is very very common, and it's just not, again, it's just not dealt with well at all. In some ways, there's almost an idea of, these things have happened and it's toughened me up and, I'm done with it. Yet you are still expressing different um, symptoms of, for example, like post-traumatic stress disorder. So just feeling as if, the next shoe is going to drop, something bad is going to happen, always on edge, um, just irritability, arguing, wanting to start a fight, not being able to concentrate. Um, I would say trauma is probably one of the most common ones. And then if you're talking about anxiety and depression, very, very common because again, there are very unique stressors as being a black male or a black female, and trying to navigate through American society where they're just very unique stressors that you have. And continuing to have that kind of stress on you, it does play on your mental health.
Mhm.
Overall, if you want to talk about overall in general, I mean, it's a very stressful time to be an American, uh, and for various reasons. You don't need to really go into it because, I mean, anybody, you go on Facebook, you go on TV, wherever, it's in your face all the time. So having that level of stress on you does play into your anxiety and also depression. So I would say those are really big. And it's real because I will tell you after the election 2 years ago and the results, the next day, when I was seeing patients, I had to send one to the ED because they were literally suicidal. So this is real, and it really affects people. And it really is important to understand, mental health is health. It's just another specialty of healthcare. And I think that's important um to understand and accept.
Hmm. Excellent, excellent. Patrick, you have your hand up?
Yes, for Dr. Duncan, you're really in a tough place, right? Because a lot of what you deal with is so important, but it seems so as a matter of fact, you know. And you mentioned trauma, and trauma, to the average person may seem like it's something acute, right? A punch in the face that causes an injury, a car accident that takes someone's life, or in certain neighborhoods, a gunshot wound. But trauma is broader than that, right? So if you could just talk a little bit more about the types of trauma that impacts one's day-to-day mental health.
Sure. And that's a good point. Trauma is not isolated. It is not defined as just being isolated in one specific situation, right? Trauma can also be, one thing that is again important to talk about is something like intimate partner violence, for example.
Hmm.
If you are in a relationship and you are being abused physically, verbally, etc., for multiple years, that is trauma that is continuous. If you are, things like, um, stop and frisk, for example, you're a young black man, you're trying to go to the corner store, you're trying to go to work, etc., and every day you are freaking out because you know that some cop is going to yoke you up against the wall and start to search you just because of what you look like. That is traumatic. So there are certainly situations where you will have continued trauma all the time. And in that kind of situation, it's very difficult to even say, is there any kind of quote unquote rest period? Because it's just something that you're going to be thinking about all the time. Your interactions with other people, you're going to be quite frankly cold because you don't want to open yourself up emotionally to others to now feel that level of trauma again.
Hmm. Hmm. And I'm just going to add to this. What I think about is those of us who are in education, um, who are in school, either high school or grammar school or college, and you're one of very few Black people sitting in the audience and understanding that you have to compete when you're that minority situation. That's even trauma. That's an everyday ongoing anxiety that you have to deal with. So those type of things are very, very important. As for, there are so many minute things that we come in contact with every day that's trauma that we don't really, and we experience it unknowingly and don't even realize it's trauma, basically. And then, people ask, well, why is he so angry all the time, or why does he have to answer like that? It's because of that interaction that they get throughout your life, starting as a young child even. Dr. Garrison, you have your hand up, please.
I don't know if this is a question or a comment, but I suffer from PTSD. And where it started was when some guy like Anderson slapped me on my butt in the very beginning when I was born. And it carried through the rest of my life. As you were referring to, Omar, every interaction I have on every day is traumatic. And some of it you just can't help. I
Mm-hmm.
mean, even in relationships, you're not only dealing with your trauma that you felt, but you're also dealing with your spouse's trauma and the things that they're feeling and everything. So I don't know if I have a question or a comment, and you alluded to the political situation. I am angry. I am angry, and my fantasy mind. I wish I was in a room with this orange guy. I would beat the shit out of him. I um, that, I was talking to somebody this morning and this woman was crying. She just says, I don't have any hope. They have snatched away my hope and what I have to say to me is like 3 years is a very short time. Okay. That it may get better. And that's where my faith and my trust and my faith comes in. But I guess the question I have is we deal when we're talking about, we deal with people in the acute situation when they come in. But what about the rest of the normal people like us who are suffering the same similar PTSD? How do we get that message out? How do we serve the community in a broad sense as opposed to only in the acute sense? What kind of initiatives are going on to address these things? When our community is inundated, every corner got a liquor store on it. They've legalized marijuana now. I can't even go out to dinner with having that skunk smell around me while I'm eating my meal. And it's like, and the young people, I'm going to work at 7 o'clock in the morning, people waiting for the bus to go to work and they're smoking a joint. It's like, because it's legal. Um, there is this sense of we've enacted laws but our morality is gone. There's no civics in our lives. How do we what kind of initiatives? I mean, how do we address this on a more of a global community-based thing as opposed to just in the acute situation when they show up in the ED? How do we let people know that you're suffering? Even when you feel good, you're still suffering with trauma or you're suffering with depression. Depression doesn't just come because you're feeling bad. You can have high anxiety depression. Maybe I didn't characterize that right, but you're nodding. I think you know what I'm talking about.
Yep.
So if you could just kind of like talk about that.
Sure. And I think that again is a great point to actually talk about is, one, first and foremost with regard to presentations. I mean, it's the same thing with regard to medicine in general. Somebody can have high blood pressure and diabetes at the same time, and you need to, treat them. Same thing with regard to someone being depressed and also having anxiety. You certainly can have both at the same time. Um, somebody who has schizophrenia can be depressed as well. Like it doesn't mean that because you have one, you don't have the other. And the big thing that I really trying to emphasize as well is you can have a medical issue, you can have unfortunately kidney failure, etc., and be depressed at the same time. Does not mean because a person is depressed that their medical problems disappear. And I have found that in some situations, as soon as there is a severe like psychiatric problem, all the medical problems are ignored, and that's problematic for the person. So that's the first part that I was talking about. With regard to initiatives, one of the big things that I would say is, first and foremost, there is a psychiatrist shortage. There are not enough psychiatrists around. And if you're trying to find a Black psychiatrist, it is very, very difficult just because of how few there are. One of the big initiatives that's encouraged now is really trying to address psychiatric issues in primary care. Um, there are some situations where you're not getting in to see a psychiatrist for weeks on end or months on end, but you could get in to see your primary care provider if you are really looking or presenting as feeling depressed or anxious, and it's pretty, moderate per se. Even if you're getting referred to a psychiatrist, you can start an antidepressant at that doctor's office and then continue on. There are, and the name escapes me. I will look it up and explain it later. But there's something that is run out of one of my mentors. She is a child and adolescent psychiatrist, Dr. Wells. It is a program where, as a primary care provider or a pediatrician, you can sign up. And what if you think that finding a psychiatrist is difficult for an adult, for a child, I mean, I don't want to use the word impossible. It is, I've heard 6 months, 7 months to actually see a child psychiatrist. So the idea is actually getting primary care providers very comfortable with addressing psychiatric issues with children and starting medication and basically getting a curbside from a child and adolescent psychiatrist. So there are several initiatives in that way. Additionally, really encouraging like synergy, or there shouldn't be a competition between, church and really finding, divine support or intervention with regard to how you're feeling, and then going to see a psychiatrist or using medication. They shouldn't be competing with each other. It should be a combination. There should be a collaboration. So the idea of finding places where we congregate or tend to congregate, and even educating, for example, pastors or barbers, and hey, these are very basic screening questions you can ask about somebody if they really are not feeling particularly well, with or struggling with their mental health. Here is a list of questions. If they are, ranking positive on this is probably, this is probably a depressive looking situation, or this is anxiety. Here are some resources for me, for you to go and look further. So there are different efforts as a community that we certainly have, there are out there. But I think the resources really need to be promoted more than what they are right now.
Mm-hmm. Mm-hmm.
Just to follow up on that, I think your answer was really, really great, but I think it leaned more towards when the patient is in the office or when they're in there. What I'm asking about is there's a statement, you don't know what you don't know. When the liver is sick, you get jaundice. When the kidneys get sick, you pee in blood. Those are telltale signs, but people don't know that the brain doesn't say, hey, I'm sick. What the brain says is like, what did Richard say? Why you kill everybody in the house? They was home. Your reality
Mm-hmm.
testing is off in that. And what I'm asking is, how do we break down those barriers, the barriers where in our community, to think that you might have a mental illness, whether it's short term or long term, is to be, as you said earlier, a weakness. Or I'm not crazy, how
Mm-hmm.
do we break down those barriers? What is it? I know what I can do when I see a thing, I speak to that thing. I've gotten rebuked by people like, My wife will say, Jordan, don't say that to those people. But
Mhm.
there are times where, you could see there's obvious all the signs. But how do we break down those barriers that we don't look at it as a negative thing to see a psychiatrist or to speak to a therapist? That's a big barrier.
Mhm.
What is your suggestions?
So,
Jordan, I
Yeah.
was thinking about that, and if we step back, and I think there are avenues in our neighborhood, in our culture, and what we do that we can, if we can get it out there that it's a major problem, that there are ways that we can do this. And number one, I would say the churches are a big issue. I mean, that's someplace that and that's why when we first started going out doing the doctor's lounge in the churches, that's why we did the churches because people felt comfortable in the churches talking about their
Hmm.
medical problem. So
mhm.
that's a big, big issue. I think
Hmm.
number one. Other than that, there are other different clubs like our fraternities. If you're in a fraternity or a sorority and you got your sisters or your brothers around you, there are those in those fraternities that you feel comfortable enough to talk about, or that issue should be brought up so that even if people don't realize that they're in that situation, then maybe they will say, well, dag, wait a minute, I feel like that. You know what I mean? Maybe I am a little depressed. I didn't realize I was, but maybe I am. And, different clubs and different things like that. So I think we have to broaden it out a little bit and let our
Omar,
community
it's
know.
an interesting conversation, right? Because that's why I'm saying Dr. Duncan is in a really tough place, right? So, Jordan, we guys we believe in parallels, right? So, and if Dr. Court was here, he would say, there's a group of people who don't come to see us until they're having pain, and their pain, physical pain, is the only indication that something is wrong, that they're quote unquote sick, right?
Mhm.
On the mental health side of things, oftentimes someone else has to recognize that something is a little off. She's not coming to bingo anymore. She's having this weight loss. She's withdrawn. And then when folks come to us with specific complaints, we actually have physical benchmarks that we often can measure, right? Whether it's a blood pressure, something we can touch and feel and palpate, right? Dr. Duncan, he's got to sit there and he's got a probe, right? But his probe is not an instrument like we have. You know what I mean? His
Yeah.
probe, his thought process. Dr. Doug, if you could just touch on some of the ways, some of the tools that you use to identify what's going on with people. And the other piece of it is, you identify someone in front of you. Oftentimes, I'm sure, just like I often say, the majority of breast cancers are identified by patients, right? The guy you're not seeing, who everyone else knows is having an issue, are there tools that you yourself can offer that you can advise us to use to identify those patients that we can refer?
Yes. So the first thing that I would say is one of the big things for us in psychiatry is what we call collateral. So trying to get an understanding of how this patient has been navigating outside of the hospital, if we're talking about, outside the hospital. Additionally, even in an outpatient setting, if this is somebody outside, it would be the same thing. Has their behavior changed? So when we're looking at things that you can look at, or if you are trying to gauge how somebody is, or how they're kind of operating as just non-physician, non-medical, but this is a family member, a friend, etc., and you're concerned, really trying to find out if, one, their behavior has changed. If they're happy-go-lucky and they're going out all the time, now they are more pessimistic, they're isolating to themselves. Are they making statements that are hopeless or useless? And then one of the big things is really addressing and breaking the stigma of talking about suicide. It is just one of those things where it's around. It's like that white elephant in the room. It happens. People do it. People attempt. People have
Hmm.
thoughts about it, but it is not talked about. And it's a problem because what should be happening is, if somebody is feeling comfortable enough to, or you have a concern. Let's say you have a concern for somebody having thoughts of that. You ask them straight up, do you have thoughts of wanting to end your life? And if that's the case and they say yes, there shouldn't be any judgment. What should happen is you're removing dangerous objects or
Mm.
weapons. You are now making sure, one, don't leave them alone. Um, Again, make them feel comfortable with regard to the situation and not be judgmental. And again, looking at using the helpline of 988, which is the suicide prevention hotline, as compared to using 911. And the reason I say that is there is a different skill set when we're talking about the differences in both. If you are calling 911 and the cops do show up for something like that, some of them are not trained with regard to how they should be approaching somebody who has a mental health crisis. Um, if you are calling the cops, and there are certainly situations where that needs to happen, is there danger? Is this person dangerous to themselves? Are they dangerous to others? But then even with regard to that, requesting for a crisis intervention team or something, um, because it's not a regular visit, right? With regard, and I'm saying visit, it's not a regular call for police to come to something like that. I've certainly had situations with patients that come into the hospital or come into the an inpatient unit, and they have really bad experiences with regards to their interaction with police, because police are there to protect and serve. They're there to stop. There isn't a context of, well, this person is having a mental health crisis, and therefore, the violence that they're showing or them being super irritable right now, I should be addressing this differently. And I'm not knocking them. They're not physicians. They're not psychiatrists. So there is an importance with regard to even trying to know the context of how you're addressing these things. It's very important.
Mhm. Can you do one thing for me? That number that you stated, you said it very fast. Can you tell us, is it nine? What is it? Nine what?
So 988
Mm-hmm. Mm-hmm. So
is
that's
is
the
a number.
number, right, for any psychological problems or any
Hmm.
problems that you feel it's a psychological illness, call 988. All right.
Yes.
Yes, yes. We have several questions. So, Jordan, what I'm going to do is I'm going to allow you to come on and do your thing with your hand up, but I'd like to get to some of our questions that's coming up as well after you.
Okay, Dr. Duncan, I'm reaching out to you for a therapeutic intervention for myself. Okay.
Okay.
I have practiced obesity surgery for the last 25 years, and I've segued into vein surgery. Vein surgery for varicose veins and chronic venous insufficiencies are the typical diagnosis. The greatest risk factor, and 30 to 40% of my patients are obese. Now, the therapy I'm looking for is how to approach these patients, because my history has been I've told the patient they're obese, and the conversation is segued into their obesity. I have had several reviews written online that I didn't come here for him to talk to me about my obesity, just fix my veins. I have not
Mm.
done surgery on patients to fix their veins because they're obese. And my surgery is like pouring water into the ocean and expect it to rise. It's not going to work. So I'm in a dilemma of, and I'm sure Dr. Lee sees this and Dr. Anderson sees this, and Omar with your pulmonary, the risk factors or the causation of it could be the obesity. And so, how I need a suggestion or a solution of how to approach these patients, because they're totally resistant and oblivious to the fact that they're obese. And so, we want to address it and help them with that. But I get either hostility or resistance or pushback. So, I'm open for suggestions.
So, I mean, I think one of the first things that I will say is everybody's not going to like what you say.
Or like,
Even if you're telling them the truth, everyone's not going to like what you say. I think words are very important, and it's how you say it. But even sometimes, even if you're saying it in a way where you're trying to be very conscious of how the person is feeling, etc., it still may come off where they are not happy with regard to it. When you talk about obesity, it is a particularly very sensitive subject. And what I did want to talk about was, when we're talking about obesity or even bariatric surgery, one of the things that I see is, I think there's an important part of, you get the surgery, yes, but and it will help you lose weight. However, is the behavior changing? Are you going? I mean, I understand that your stomach is smaller and therefore physically you may not be able to eat as much. However, have you now understood that you behavior wise need to decrease this? Also, what is the root cause of why you're overeating or why this is going on? So trying to explain in a way where you're saying, hey, like, this is going to help with regard to these varicose veins and lightening them or getting rid of them, but this could be a reason why, with regard to, medicine does not fall in silos, and these are risk factors of why you have varicose veins and why these things need to be addressed as well.
Mm-hmm.
You can try and explain it that way, but I cannot guarantee that that's not, somebody's not going to be annoyed about that.
Mm-hmm.
I mean, I've been in situations where, it's a child who is very, very depressed and is going into an inpatient unit, and they're going to be started on medication. There's no question about it. They need medication. And I'm talking to the parent, and the parent is telling me, well, in my day, fresh air and going outside was all I needed. And I get that, but this is a different situation, a different person. So even, I mean, I could explain till I'm blue in the face. If that is what their core belief is and they don't want to hear it, they don't want to hear it.
There was another way to look at that as well, Jordan. I deal a lot with weight loss, and even in writing a book for weight loss. Um, and I looked at it from a psychological point of view in the past, and I realized that for our neighborhood or people of African descent, there are very few things in life that we can truly control. We can't control the job that we have. We can't control the amount of money that we make from that job. We can't control, so many things. Being a black person, you just have no control. But the one thing you can control is how much and what you eat. And when you try to relate that to, and even that is a way of expressing depression. Because now, if I feel bad, guess what I'm going to do? I'm going to eat something good. I can control, and that makes me feel good. So the more depressed I get, the more I eat, or I eat what I shouldn't supposed to be, what I'm not supposed to be eating. If you understand what I'm saying, so that is something that eating and how you feel is so connected. It's something that I think in our culture, and it comes down to, soul food is the greatest food in the world, greatest tasting food in the world, but it's high calories. You know, I mean, there's all that fat and the sugar, and if you eat that all the time, you're going to get big. It's just inevitable. So it's just in our culture that we use food as a way to deal with some of the stresses in our lives.
Mm-hmm.
Do you find that as something that you've come in contact with, Dr. Duncan?
So yes, when we talk about, how we're addressing things. So when you talk about like eating your feelings, for example, very common. You talk
Eating your
about, for
feelings.
example, and this was something I wanted to segue into, just because that is my interest. You're talking about substance use and why. What is the root cause? I mean, quite frankly, and speaking very frankly, someone doesn't wake up, they don't wake up on Saturday morning and say all of a sudden spontaneously, I'm going to use crack cocaine. It doesn't work that way. There is a reason why. There are things that happen. There is an event. There are things that go on step by step for them to get there. Why is it that they are using what they're using? Why is it when you try to get them on, you know, a road to sobriety that they fall off again? There are different factors that go on, and that was what I was going to talk about, you know, today, talking about community psychiatry and really the idea of when we see patients, or, you know, if you're seeing them in a hospital or even in an outpatient clinic, you're seeing them for a cut period of time, an hour, maybe less if you're pressed for patients, etc.
Yeah.
And if you start seeing this patient, or you say, you know, I want you to do X, Y, and Z for instructions, and then they come back 2 months later and haven't done anything. If you're so quick to think about it, just like, well, what did you do? You didn't do anything. Like, I'm wasting my breath. But you're not factoring in these variables that they deal with outside.
Mhm.
Mm-hmm.
Yeah, if I might ask a question, Omar, you know, on the physical medicine side of things, and just to kind of separate and highlight the parallel on the physical medicine kind of things, you know, we look at and a big talking point, and Jordan, you know, often has something to say about this, is systemic bias in medicine, right? And one of the highlight and the big talking point now is maternal and neonatal mortality in our community, right? And as hard as we try, you know, we look at and practice in an urban area like we do, where such a subject is sensitive, you can see where systemically there are efforts to identify biases, intrinsic biases, and to deal with them, right? And, you know, a few years ago, you know, I presented a paper at the International GYN Cancer Society looking at, you know, outcomes of managing uterine cancer in such an urban area where the population is mostly people of color, women of color, with the primary practitioner being a person of color who should understand, right, such dilemma. And what actually came out of that abstract is there is still a difference in how we approach some of these patients. And you know, some of it has to do with not intrinsic biases, but systemic disparities, right? Food desert, some of these patients are in the food desert. Some of these patients, when we talk about access, even though the service is available, they just have lack of access to get to those services. You know, when we look at the stage of presentation and the portal of entry is, you know, more than 40% of these patients, the first time they enter into the system for this particular reason is through the emergency room, oftentimes in a moment of crisis, right? As depicted in the advanced stage. How do you see that on the psychiatry and the mental health side of things?
So it's very similar. And I agree. I mean, there's documentation, there are studies, I mean, plethora of studies that show that there is still biased with regard to approach for patients, with regard to even you know, with regard to diagnosis. So for example, when we talk about, you know, black patients, they are more likely to be diagnosed with schizophrenia as compared to you know, mood disorder.
Mm-hmm.
And if we're talking about stigma in general, I mean, schizophrenia is like a scarlet S.
Mm-hmm.
If you see schizophrenia on a an EMR, it's just like, all right, well, you know, this is going to be a problematic person, etc.
Mm-hmm. Mm-hmm.
You know, and it's very different if somebody, in fact, it has something else as a diagnosis. So what I would say is, in psychiatry, because of how personable it is, and just in medicine in general, you see that patient compliance or outcomes improve when your provider happens to look like you, happens to be in your community, etc. It is even more of a thing when it comes to a psychiatrist.
Mm.
If you go into the ED, and I could tell you multiple times, if going into the ED or in an inpatient setting or outpatient setting, culturally wise, there are things that are, if you are not part of that culture, um, there can be something said that you may be psychotic because you pray every day, or you believe in the Holy Spirit and speaking in tongues. That is something
Mm.
that some people do not understand and
Understand.
will
Hmm.
literally say that
Hmm.
you are psychotic because of it.
Hmm.
I have had to, as I was actually an intern, as an intern, have to push back on notes that were written in a chart for a patient because older middle-aged Southern gentleman and had been in the inpatient unit for months. And that unit, you're not allowed to go outside. So you're in this unit, there are few windows, etc. And when we ask them, how are you doing? Just holding on and holding on to God's word and really hoping that tomorrow is going to be better. And that's what he kept saying every day, very politely. And what I saw in some of these notes where a patient is religiously preoccupied, psychotic, etc. I'm like, whoa, that's not okay.
Hmm.
So there is a lot of that still.
Hmm.
And with regard to even what we're doing here, there's an importance of advocacy,
Hmm.
and really understanding that different cultures are different.
Hmm.
Something else that was really interesting as well. My program director gave us an example at a former hospital where he was at, where the shampoo that they were using um, for more ethnic hair, when they used to shampoo their hair, it used to look very greasy and unkept. So when they would go, if they were like involuntarily committed or they go to treatment teams and how they looked, it would be written that they look disheveled and they're not in their right mind, etc. And it played into whether they'd be discharged or not. And they literally changed the soap slash shampoo that they were using. So there are a
Mm.
lot of different things that may
Mm.
may seem like they're not really important at all, and they really factor in majorly with regard to
Mm.
what's going on.
Right.
Mhm. Mhm.
Yeah, it's funny you touch on the cultural aspects of things because in the world of cancer, one of the things we look at is uniformity and how care is delivered. Are these care, standards that's evidence based, and so you look at certain environments that are supposed to be homogeneous, right? Where the principles and the concepts should be the same, right? In the open field, now we have the National Cancer Committee Network guidelines that we tend to follow. But if you take a captive environment, so to speak, like the military, right? You would think that in the military, you have the same set of resources available to you, but then, you know, who accounts for the cultural aspects that influences decision making? And I actually wasn't even thinking about the person speaking in tongues, or the older gentleman who's religious but is being perceived as religiously occupied because he starts his day by honoring God. you know um so in these gated environment where policies are supposed to be uniform across the board. Is there studies in psychiatry that say in a place like the military, the approaches are similar? And is there a measure of outcomes?
So I I do not know off the top of my head with regard to studies. I can tell
Mm.
you with regard to experience of having uh, current current military service and veterans, and
Hmm.
that the VA is just run very differently.
Hmm.
One of the things that I'll say is, I mean, first and foremost, the majority of people that you see have PTSD, for example. Yes. Um, but with regard to cultural wise, again, it depends on who is seeing you at that time. Um, I know that if I am on call with said attending, some are more conservative and some are less conservative, as in they feel more comfortable with how somebody's presenting and they will discharge them, as compared to others where it's like, you know what, I don't really feel comfortable with this. And therefore, I think that this person needs to go in. So
Hmm.
it can be very subjective sometimes. with regard to even how somebody is going to be treated or addressed just on the how comfortable a the doctor who's there and is in front of you is.
Well, to that point, I think that starts not even necessarily with the doctor. I've had some of the ancillary staff come to me when I had to go see a patient and say, "Oh, treat this patient's nice. They're a good patient." And what does that mean? Well, if a
Mm-hmm.
patient has a shirt and tie on already, there's a perception. But if they come in
Mm-hmm.
with Nikes and sagging,
Mm-hmm.
then the perception is, "Oh man, he's a thug, he's a gangster," whereas it might be the best patient in the world. So the preconceived notions from our ancillary staff, and then they come to me and tell me, well, this patient is belligerent, this patient is that, this, then that sets up a scenario where I'm going to go in there, if I'm not in my right mind, and treat them accordingly to somebody else's perceptions.
Mm-hmm.
What I try to do is I go in and see the patient with no notions. And if they
Mm-hmm.
tell me that this patient is hostile, then I go in and do just the opposite. Hey, how you doing? What's going on? Maybe overly in the other direction, because I can't rely on somebody else's perceptions to dictate how I go about it. And that's what you're talking about, the subjectiveness.
Mm-hmm.
We have all experienced that as physicians in our residency as
Mm-hmm.
we're going through, and I have been called aggressive as opposed to assertive, and initially didn't know how to deal with that, but I took it on. And now when somebody says something that hints towards that, I said, what is it that makes you uncomfortable?
Mm-hmm.
And it changes the whole dynamic. Um,
Mm-hmm.
so there's a lot of bias, and you recognize that bias in medicine, and we as practitioners have to work hard to overcome that bias and
Right.
see these patients.
It's our time here, the halftime, and what we're going to do is we're going to do our halftime spiel, but afterwards, we got quite a few questions. We're going to handle our questions coming
Mm-hmm.
back and halftime, and then we'll hit some other topics that I'm sure Dr. Duncan would like to hit. I know everybody's kind of directing him here, and he's probably got a list of things that he want to cover before
Well,
before
that's what
the
happened when
time
you're
to
the one
talk.
in the hot seat.
Yeah, this is
Omar
great.
didn't tell you the quiet part, did he?
He didn't.
There you go. There you go. Well, um, let's do this. So let's introduce each other. Dr. Duncan, can you start off, introduce yourself, and we'll all introduce ourselves again because I'm sure there are people that came in that was after we introduced ourselves. Go ahead, Dr. Duncan.
Sure. So my name is Matt Duncan. I'm currently a fourth year psychiatry resident at Ocean University Medical Center. We'll be finishing up this coming June, and then I will be starting an addiction psychiatry fellowship at University of Pennsylvania. Glad to be here. Just big interest in community psychiatry and also addiction psychiatry as well.
Excellent, excellent. Dr. Garrison, please.
Hi, Jordan Garrison. I'm board certified general vascular and bariatric surgery. I specialize in disease of the veins, and I'm very happy to be here. This is really a nice conversation. Thank you.
All right, Dr. Patrick Anderson.
Yes, everyone. Pat Anderson. I'm a GYN oncologist. I work in the Barnabas system, primarily out of Newark, Beth Israel. The physician's lounge for me is like going to the barber shop. This is where I come to get inspired. I'm glad to be here.
All righty. And I'm Dr. Omar Bey, retired pulmonary critical care fellowship, right? Pulmonary critical care physician. And at this particular point, I'm director of nutritional support for the ICU at Beth Israel Medical Center. All righty. Understand that every second Saturday we are here. All right. And please, it takes a village, as I stated earlier. Tell friends, tell family, and let them know that we're here talking about topics, and just enjoy your questions. We're going to start answering questions on the second half. And please, those out there that haven't typed your questions, if you have questions, please type them in. Don't, no matter how small or how big, we will try to answer them to the best of our ability to give you an answer from a Black physician's perspective. All righty. The one thing I can say is that if you want to see our past webinars, webinars, just go to OB Healthy, and you can hit the doctors tab. That page will come up. There is a camera there that you can hit, or go to the YouTube logo and hit that. All our past webinars will come up. Please listen and look. When you go to YouTube, please subscribe so we can continue to bring that medium to you. The most important thing I can say is please do not change any aspect of your medical care until you consult your physician. Only your doctor truly can take care of you from a medical standpoint, okay? And I'd like to thank OB Healthy for allowing us to bring this webinar to you. Without them, we just couldn't do this. All right, I think I said everything. Hopefully I did. Let's get to some questions. The first question is, can we also speak on the feelings of indifference? Indifference. I'm going to let you handle that one because that's a little outside of my borders, Dr. Duncan. The feelings of indifference.
So I'm going to smile a little bit because that's Dr. Williams. It's one of my colleagues. She's family medicine. So we talk about this dysthymia. Is actually what you call like low-level sadness for an extended amount of time. So in psychiatry, one of the things that has been done is you kind of have presentations that do not fit all the criteria for something. So with regard to, for example, major depressive disorder, you are supposed to have like feelings of sadness or what they call anhedonia, like things that bring you joy, they don't anymore for more than 2 weeks, and then several other symptoms, which is the acronym is Ziggy Caps. I'm not going to go through all of them, but you're supposed to get a certain amount of them. Let's say instead of the 5 of them, you get 4. Does that mean that you're not depressed? Because it doesn't qualify for major depressive disorder. Let's say you're getting 2 of those symptoms out of everything. Does that mean you're not depressed? You're not having feelings of depression? So the idea is having a diagnosis that's kind of what you call in between. So dysthymia is an in-between diagnosis. And how you'd be addressing that would be similar, where we'd encourage something like psychotherapy or commonly what is therapy, or potentially talking about maybe medication. And then lifestyle changes and lifestyle modifications are always things that we encourage as well.
Excellent, excellent, excellent. I'm going to keep going. Excellent. I want to keep going as far as the questions are concerned because they're mounting up, but thank you for that answer. Please, the second question, please share if depression is a precursor of other mental illnesses, or is depression usually a disorder that a patient has different levels of depression? If it is a precursor, then which other mental illnesses does depression lead to?
Okay, that's a good question. So first, what I would say is depression is depression, right? As in it is a diagnosis in the DSM that is an actual psychiatric disorder. Is it a precursor to other presentations? So the answer is no. However, one of the things that you would ask if somebody comes to your office and somebody comes to my office and says, I'm feeling really depressed, it's hard to get out of bed, having feelings of sadness and guilt, and just don't feel like I'm worth anything. So I want to start them on medication, and that would be something like an antidepressant. So we talk Zoloft. One of the first questions that I'm going to ask is, in the past, have you ever had an experience where you've been up all night, needed little to no sleep for 4 more days at a time? Have you spent money that you don't have, like rent money? Have you been particularly promiscuous? Do you feel really irritable when people tell you things? Do you feel like you're over when you talk about being like very, very ambitious, or overly positive to an unrealistic way? So what am I talking about? I'm talking about these are mania symptoms, or symptoms of mania. Because one of the things that we learn, it's emphasized, is you're not going to give somebody who may be showing a presentation of bipolar disorder antidepressants, because you can potentially kick them into mania. So what I would say is that you do have to ask extra questions, because a lot of times with regard to psychiatry and diagnoses, you look at it as a Venn diagram, where how I would explain it is, two circles that interact or intercircle each other, and you have symptoms that are very similar for different diagnoses or different pathologies, psychiatrically wise. And one of the other things as well is you could go to 3 different psychiatrists, and sometimes they would tell you something differently. And with regard to what you have, and the reason why is because, again, they're only seeing you in that time period. So you could be really, really down when you go to the psychiatrist one day, and then you go and see somebody else and you could be elevated or be, I mean, there is, short answer is no. It's not necessarily a precursor. However, depression can present in other psychiatric illnesses.
Excellent, excellent. Next question. I'm happy to see more and more offerings for caregivers, caregiver therapy, it states, as many of us now care for our parents or elders. Do you come in contact with that? Because I understand once you're caring for a elder, it can totally encompass. It takes over your life. Do you see that? Do you get those patients in your office, or or are there societies out there that can help these, caregivers? That's the question.
Yes. So that's very common. It's just something that's not talked about, right? So, in our community, taking care of the elderly or taking care of, family members who are sick, etc., it can be super draining. And in addition, you're still working, or you have all these other responsibilities to do too. So caregiver burnout is very common. One of the things that they do have, they do have different groups, like with regard to like caregiver support groups. That is something that is available. But it's also one of those things where we talk about, in a plane, if there's an issue with oxygen and the oxygen mask come down, you're supposed to put yours on before you put it on somebody else. And what do? We put it on somebody else before we put it on ourselves. So there is an importance of really making sure you're okay too. And it's certainly easier said than done. So yes, I see that a lot. Um, and it's very difficult to see it and try to give encouragement of, hey, how is your mental health? You're bringing somebody else here, or if you have somebody with a chronic illness and they're being brought by their loved one to the office, etc., and the loved one just looks spent, super tired, hardly engaged, half asleep, and it's really because they're going through it, and trying to encourage them to really just say, like, hey, like, how is your mental health? How are you doing? And they're kind of just like, I'm all right, but I need to focus on the person that's in front of you now. It's difficult. We give resources, but at some point there has to be buy-in by that person too.
I got you. I got you. Very good. Very good answer. Next one. I found trauma and food insecurity a significant risk factor for obesity. How can we better address this?
So again, Dr. Williams, great question. You know, I think we did touch on that before, right? So
Mhm.
we're first and foremost, we're talking about things like food insecurity or financial insecurity. These are traumatic experiences. And if for example, if that's something where there was, a scarce resource like food, you weren't sure when your next meal was going to come from, you're going to a food pantry and the food is not, the variety isn't great. And then later in life, you're doing well, you have this job, and at this point, it's just like, I'm going to eat what I want because I didn't get to do this before.
Mhm.
Do you know how hard it is to come to try and tell somebody, like, hey, you are eating your feelings as well right now, right? You realize that you're now doing this because I wasn't able to do this before. It's all about language. And again, sometimes people are just not, they're not going to be receptive to it. or they're not going to be receptive the first time you tell them. But how you address it is really trying to link them together. These are not separate things. And this is why, or this is an issue with regard to not being able to lose weight, or not being, or why, you know, your cholesterol is wild, or why your blood pressure is wild. It's these lifestyle choices that you're making now, and I get what you're doing or why you're doing it, but do you, or you know, it really, psychiatry is one of those things where, you know, and I make the example with blood pressure medication, for example. You start blood pressure medication, it's supposed to work. It's supposed to work right there and then. I can't tell you with regard to if I see a patient for one visit that we are going to solve all the traumatic experiences that they've ever had. And additionally, in the future, I can't guarantee that you're not going to have stressful situations in the future either. What my job is to organize in such a way where you are able to cope with these traumatic experiences in the future, or unpleasant experiences in the future, where your stress level might go up to 3 instead of going up to 10 again, and not being able to function.
Right, right. Well, Jordan, I know you have your hand up, but can we get a few more questions in? Because we got a lot of them coming in. Um, my daughter is in college. She has anxiety. She's losing a lot of weight, but she states that she's fine. I don't know if she's having depression or what. What do you think I should do? She writes notes to herself on sticky tabs all over the room when she's here, when she's home during the holidays. Is this normal?
So, you know, I like to be very transparent with patients. I like to be very transparent with you know, the public. The first thing that I would ask is, was this a behavior that she had before? With regard to writing the sticky notes. Also, what kind of context are on these sticky notes? What is, she writes these notes to herself? Are these, positive in context? Are these negative in context? What exactly is going on? College is stressful. Okay, I know that it's promoted as one of the best times of your life, and in some ways, yes, you know, you really are able to learn and experience different experiences, but can also be extremely stressful. And for a young adult,
Mhm.
this may be the first time that they are experiencing that unique kind of stress. Because of that, this is some of the first times that you have somebody who is experiencing things like anxiety or depression.
Mhm.
So what I would say is, you know, even with regard to the weight loss, I mean, is she not eating as much as she was before? Why is she losing this weight? So one would be really answering the question of, is this behavior significantly different from what she was doing before she went to college? Additionally, I mean, the college is more or less required to have student services.
Mhm.
So it would be encouraging her to go to, you know, student services, whether this be going to a therapist and or even going to a counselor, like an academic counselor, and just being like, hey, you know, classes are a little bit more stressful than I think they are. What kind of advice do you have for me? And really looking to address that at several angles.
Excellent, excellent, especially with the student services. And
Mhm.
they have the student clinic there, usually on a college campus, and there are many, many avenues to assist a student in a college setting. They just have to seek it out. That's the question, because a lot of times the students don't not they aren't even aware that it's available to them. And if they seek it out, it really can help. That's for sure. The next question: I'm in school. Does writing in my journal every day, all right, help me with depression?
Yes, so that was one of the things I was going to say is a strategy with regard to keeping your mental health on keel, or trying to improve your mental health. Journaling is very effective with really helping. It can be something, you know, non-medication wise that can help. The idea is with journaling, or even if you're journaling, you know, daily or even weekly, writing down your feelings for that day and then self-reflecting on them is really it can be really important. Um, I have patients in psychotherapy that, I encourage them like, hey, I want you to write a journal down of, what you're thinking for today, what kind of interactions you're having, how you're feeling, etc. And they're going to come back and we're going to talk about it.
Hmm.
So the short answer is yes. Yes, it can be helpful.
Excellent. Another question. How can we better address cultural
Competence.
competency both with inpatient and outpatient?
So it's all
Mhm.
about, education. I mean, I'm still at the resident level for a little bit longer, but at our level, they force us to have lectures. And I think the big thing is really the implementation of it. I
Mhm.
certainly don't know everything about, every culture there is, but
Mhm.
there's an importance of making sure that a patient feels heard. I like even using those words. I want you to know that you are heard. And with regard to looking to help you today, I want to know that your concerns are being addressed and acknowledged as well. And that goes a long way as compared to just being super dismissive with regard to the concerns that a patient has. I mean, that just destroys the doctor-patient relationship.
Mhm. I think that that's not only in psychiatry, but across the board with physicians. And what we find is that so many physicians are foreign physicians, especially in the African American community, and they may not understand our culture as well as they need to understand it to truly, um, connect with the patients that they're treating. Some of them do a very good job, with connecting, and others do,
Mhm.
less of a good job. But I think that's something that some of the hospitals are trying to deal with giving physicians, trying to educate the physicians about being more sensitive to the cultural aspect of the patients that they're treating.
Omar, I know in the Barnabas system there is the net learning, the online courses that, are required for employed physicians.
Hmm.
I don't know if that's offered to the voluntary faculty, but the learning and is one thing, but is there a measure of
Hmm.
competence, right? And is there a way to measure ongoing practice of competence? And I think, with the electronic medical record system, there can be tools that can be implemented, even if it's just a set of questions that, you know, they can go back and look and say, well, did Dr. Duncan ask all these questions? And that can somehow be applied to a measure of competency, and then they can go back and look at the number of times you use it, and so on and so forth. I think part of the problem is it's one thing taking a course, and answering all the questions, but then there's a whole nother question is whether it translates into continued practice.
Mm, interesting, interesting. Um, we're going to do one more question, and then Dr. Garrison, I'm going to get back to you. Okay. Um, what are your personal views on the use of cannabis to treating anxiety and PTSD? Mhm.
Yep. So here's what I will say with regards to that. In the short term, things like cannabis or even alcohol use in the short term has perhaps a mild effect on maybe helping with regards to anxiety or depression. However, long-term wise, it certainly can increase both anxiety and depression. I can't tell you the amount of times that I get consulted for a patient with like cyclic vomiting syndrome, or they just wild anxiety that they come in for, that they think they're having a heart attack. And when I talk to them, they're just like, well, I smoke weed a lot. And it's the only thing that keeps me from being anxious. I'm like, no, that's the thing that's making you anxious right now because of how much you're smoking. One of the things that is important to talk about too with regard to marijuana and marijuana use is if you do have a history of like bipolar disorder or schizophrenia, it can actually, kick you into, a psychotic episode. And there is an importance of understanding that because the amount of people that I see that come into an inpatient unit multiple times because they leave, they use marijuana and they end up having to come back in again. So it is a medication that is medication. It is a substance that is mind altering. Um, and there are certainly risks with it. Does it replace psychotherapy and if needed medication? No, it does not. And that's really a firm answer for me with regard to that.
Hmm. Excellent, excellent. Dr. Garrison, please. Thank you for being patient. You're muted.
Dr. Duncan, you've mentioned it briefly before, and you just spoke about drug addiction, and I'm sure you're going to get into that if time permits, and treatments for that. And we were talking about obesity, and I look at obesity as a type of addiction.
Mm-hmm.
What I know about it is there's three factors: the physiologic factor, um, the body, and I can fix that in 2 hours with surgery or withdrawal in 30 days. The drugs or the is not a factor. Then there's the sociologic. It's like, where do you live? If you're, as Omar was talking about, soul food is real good, and if that's all that you're consuming, that's I can't fix that. But my question is more for you for the psychological part. What are, if you can tell me some of the techniques that you use to address that psychological part, and how can I partner with you to support your efforts in that psychological part?
Sure, sure. So I think it's important to understand, we want to talk about perception, right? Or a term I'm sure that everyone, kind of knows here. I'm talking about the doctor section, is like body dysmorphia, for example. If I have a perception of how I'm looking, it doesn't matter how much weight I lose, it doesn't matter how much I go to exercise, etc. I have a perception of how I look. And therefore, it is very important that there is a psychotherapy, psychiatric component when it comes to, weight loss or even bariatric surgery, because as you said, you're addressing the physical part of this, right? Even with regard to environment, you could address that as well. You're helping them with regard to getting on a diet plan or organizing like food replacement kinds of things. But if this patient is not psychiatrically, like there are things that are not addressed, whether this be underlying depression and that's the reason why they are jumping to food, or their perception of how they look, etc. It's very difficult for all the other things to work well. So what I would say is that I look at it as hand in hand as compared to one being more important than the other. As in, I this was something that I used to say for all of my interviews when I was applying for residency, and I explained, the uniqueness of psychiatry is I find that it can be applied to every other specialty. And I give the example of, orthopedic surgery. Somebody, breaks a bone and they go into surgery. Now, it could be the best surgeon in the world. And post-surgery with regard to those post-op instructions, if that patient is super depressed, super anxious, has some other underlying mood disorder, etc., they're not going to be able to follow those instructions. They are too psychiatrically unstable to do it. So there is an importance of really making sure that psychiatrically or their mental health is good so that they can go through that process. So I see that as the same with regard to somebody who's looking to lose weight, whether it be with use of it being like bariatric surgery or just weight loss in general. Are you mentally ready to go through this journey? Because it's just as important as the physical part.
Mhm, mhm.
So what are your techniques for addressing that? And again, how can I support those techniques or those issues?
So I think the first thing, and we use these words a lot, but like root cause. What is your reason for wanting to lose weight? What is the reason? Is it that you want to lose weight because you want to be healthy now? Is it because you want to be around longer for your children? What's the reason why? What is your why? That would be the first thing. To really have them understand, get an idea or be able to answer for themselves why they want to do it. Additionally, even understanding what the process is. This is not a quick fix. Bariatric surgery is not a quick fix. And there are potential complications. There are a lot of other variables. And I do find with regard to medicine and how it's promoted, and I'm not talking about physicians because they're not the ones doing it. Just with regard to commercials on television, even hospitals and saying, we have this surgery and that surgery, there are complications potentially. There are different things that can happen. And is the patient aware of this? I think it's important for them to know what they're getting into as well, because if they're now in it and it's just like, well, this is much more difficult than I thought it was. I didn't realize that I wouldn't be losing as much weight as I was before, or my behavior has to change now. Like I still want to eat everything, and I can't. And I'm really upset about that because that was my go-to for stress. So there's an importance of going down the line of preparing yourself mentally for this journey. I think that's super important. And really just emphasizing that it is okay to have a therapist, or at least, I mean, first and foremost, if you go and you see a therapist and they're just like, all right, you're good. Or, come back in 6 months and we'll see how you are, after you've had the surgery and, how you're doing with your progress. There's nothing wrong with that. So really trying to normalize addressing the psychiatric component of this is important.
Yeah.
Appreciate it.
I think there's a big psychiatric component as well. So many patients that, because, I used to work with the bariatric surgeons a lot, coming in, dealing with the patients that are overweight and referring them and then evaluating them prior to going into surgery, things like that. And then following the patients. And a lot of the patients initially, when, the bariatric surgery was back in the day when it was a different type and people were having vitamin malabsorptions and stuff like that used to follow. But the one thing I did find, and psychologically, I think you're right on the ball as far as Dr. Duncan is concerned. I used to say you can nibble yourself fat, you know, and you don't have to eat like the largest meal, but it's all about calories. So if candy is what you like and you nibbling candy all the time, guess what? That weight is not going to come off or it's going to come back. And another thing I've always thought about, and it was deep thoughts, is that how many patients did I know that had bariatric surgery 3 to 4 years later are the same size they were prior to the surgery. You know what I mean? Lost the weight and gained the weight back, even though they had the surgery. So, psychologically, definitely, it's hand in hand, and you can't. I don't think anyone's successful with only one aspect of that.
Yeah, there's a statement that says no matter where you go, there you are.
There you are. True.
Behavior has not changed, then there you are again.
Hmm. True. 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 Patrick, your hands up.
Yeah, question for Dr. Duncan. In what I call organic medicine, organic in things that we know and we can treat cancer, there are we know age-related incidences, we know incidences, gender-related incidences, and as such, we're able to establish some wellness milestones, right? What are the ages you start to do mammograms? What are the ages you start to do colonoscopies? Screen for lung cancer, etc. Um, One of the group of patients that I'm often concerned about is the mental wellness of our geriatric patients. And is there an age when one in psychiatry and psychology could say, well, this is an age when we start to see an increased incidence of certain issues, whether it's depression, whether it's subacute schizophrenia, and just the way we on the organic side of things, you know, have these schedules, right? We check off the colonoscopy was 2 years ago. Um, are there measures that we can implement in psychiatry and mental health to identify individuals who are at risk? And this is really for the primary care physicians, but to identify individuals who are at risk, who we can start to refer to you to start having a conversation based on things that we've identified.
So I think that's a really good question. By definition, usually geriatric is starting at like 65 and up. What I would say.
Jordan.
So
Jordan.
just saying, I'm just saying by definition. I'm not throwing any shade to anybody here.
We're holding on to our mental, brother. We're trying.
What I would say is, one of the things with this age group is you would see things like depression, right? And the reason why is your friend group decreases, things change. You may retire, you may not be living in your own home anymore. You're now living maybe in assisted living or a nursing home. But one of the big things is that all the friends that you have around you, people pass on. So now you're having people who may be passing on around you. So even that tribe or that circle that you have is not there anymore. So there's a level of loneliness. And what loneliness can lead to is depression. Mm-hmm. There is also something called pseudo dementia, where somebody can present and they seem like they cannot tell. They start forgetting things, their keys, etc. And what is actually happening is that they're depressed. So it's something that you can see in like the older population. So what I would say is something that you would be looking to screen for specifically would be depression, anxiety, but you would also screen for dementia, for example, to actually rule it out. So using something like MoCA screening or mini mental status exam would be helpful. Also, for things like schizophrenia or bipolar disorder, those are things that usually present much earlier. If I see a diagnosis for somebody that is 65 and up and it says schizophrenia and this is their first diagnosis of it, I would be very skeptical, because it is something that usually presents much earlier. So to answer that question, for primary care, for example, there are some very basic questions that you can ask just as screening questions. So when you talk about the two screening tools, like the GAD-7, for example, and then of course I forgot the other one. I think it's the PQH-9. These are like for depression and anxiety. Just going and the thing about it is, as a physician, you don't even have to do that. This would be like if an MA or one of your assistants goes in and asks them these questions, and depending on how they score on it, then you would ask further. But it should be part of a medical exam. That's what I would say.
Yeah, and I guess in the geriatric age group too, where there are other physiologic derangements that are occurring. Oftentimes, and Omar, you and I have had these conversations with respect to eating and nutrition. So we have a patient who had a stroke, right? And we're often concerned with the physical deficits that are result because of the stroke. But we have to understand that the brain is complex, and just where you can have physical deficits, you can also have emotional deficits that is directly related to the stroke. And to complicate matters, the patient has the ability to understand that they have a stroke, they can't function anymore. So there's the depression that comes along with that aspect of it, but the depression that comes along with the intrinsic function of the brain due to intrinsic damage as a result of the ischemia or whatever the cause of the stroke. So for a psychiatrist, I can't imagine it is an easy way to figure out which is a result of which, and which you can treat.
So my question to you would be, if it's due to the stroke, or this person just has underlying, like, if the depression is cause of, as you said, ischemic damage, or like an actual like infarct to the brain, as compared to uh and they're depressed because of that, as compared to underlying depression, um would the treatment be different? And what I would say is probably not,
Right.
right?
Mhm.
So there is a strong correlation for stroke and post-stroke like depression. That is
Hmm.
true.
Hmm.
Remember, as being a very nervous, humble med student, going in and seeing a patient who had a stroke and was very severely depressed as well because of it. The idea with regard to that is, certainly looking to address the depression the same way you would address depression.
Hmm.
Um, so you know, it is each age group, each population, where it be gender, female, male,
Hmm.
ethnicity wise. These are all factors that do have to play into how you would address, or what is more likely for you to be concerned with
Hmm.
focusing on. But it's at its basis, there really should be an evaluation, or a psychiatric evaluation, that is included in your uh, physical exam
Hmm.
when you're seeing one of these patients.
All right. Excellent, excellent. Dr. Garrison, your hand's up.
Yeah, quickly, I understand there's a difference between, I don't know what garden variety depression versus situational depression. For instance, I'm going through a job transition. And, for a week, I was like, oh my God, what am I doing? Where am I going? And everything. But that lasts for a time, whether it's a week, 2 weeks, or whatever, may or may not need short term medication. I didn't need it. I just went and put the dog in the microwave or something like that to get
Well,
rid of
you're missing something that you had truly have there, Jordan. Medical marijuana wasn't just meant for patients; it was also meant for provider as well.
it.
Now,
No, man, no. Nah,
So,
I
Dr.
don't
Duncan,
do that.
Jordan is the only one of the few people you can pull his coattail all the
Uh,
way down the street, and he just turn and wave at you and laugh and walk
uh,
away.
I know Rasta. Okay. But actually, that was just a comment. But
Mhm.
there are two really interesting questions still in the queue.
Yeah,
And if we could get to those, Omar, I appreciate
yeah,
it.
yeah.
Okay.
The next question I wanted to get to, and it's a good one. For the sake of completeness, how does the trauma of persistent or consistent malnutrition plays
Mhm.
into the mental health challenge of
Mhm.
depression? I believe the optimal nutrition changes that optimal nutrition changes the biochemistry, changes the behavior. The thoughts of all members of the panel are welcome. So malnutrition, he's right in my area there as far as malnutrition is concerned. Um, I think we are what we eat. And at the cellular level, if we can give what our bodies need at the cellular level, believe me, the body is an enormously wonderful organ. Not organ, but group of organs. And all we are, if you really think about it, We're just billions and billions of cells talking to each other. That's all we are. So if we can give those cells what they need to be healthy and to function normally, we move forward. And if we abuse it and give them things or expose it to things that are harmful, then we suffer for it. So, I mean, that's just they said everybody had their opinion. Why don't we start with Dr. Duncan and go around?
Sure. So I did want to just circle back really quickly, the collaborative that I was talking about with between child and adolescent psychiatry and pediatricians and family med docs is actually called the New Jersey Pediatric Psychiatry Collaborative. So that is something run out of Jersey Shore Medical Center. So just for completeness sake, as we were talking about that before. With regard to, I'll give the example of the Head Start program. So you have children who are going to school in the morning. You have some that have a full breakfast as compared to ones who didn't eat anything for breakfast and they sit in class. Which student do you think is going to do better in that classroom at that time? If I'm hungry and I didn't eat anything and I'm sitting there, I'm going to be irritable. I'm going to be annoyed. I want to know why I'm here, as compared to my counterpart who has had something to eat, is going to be willing to participate, etc. So they certainly have had studies that show the improvement with regard to academic achievement if somebody has a full breakfast or a healthy meal for breakfast before starting school. So yes, with regard to nutrition, nutrition is an important part of your mental health. There are studies that show with regard to even what you're eating. There can be issues with regard to it causing inflammation. If somebody is constantly having inflammation and pain, very likely that they're going to be having things like anxiety and depression. So they all connect to each other. These are not things that fall in silos. So I agree very much so. Their malnutrition certainly would make the challenge of depression much more complicated because now that's another variable there for food insecurity.
Yeah, I mean, I do appreciate this question. I think it's a really, really interesting and important question because the fact that I'm not hungry doesn't mean my nutrition is optimal, right? And I think optimal nutrition has everything to do with supporting, enhancing all the chemical reaction that occurs on the cellular level. So why we talk about the macronutrients, number of calories, protein, fats, carbohydrates, that's one thing. But is that meal have all the micronutrients that enhances, all the reactions that enables a cell to function efficiently? And we know the brain is persnickety, right? The brain, not everything that the liver and the lung will absorb readily. The brain will absorb it readily, right? And then you talk about the things you eat that are stimulants, right? That quote unquote give you energy, that are attention promoting, right? When I went to college, most of us had no dose, right? Now these guys, they have all kind of energy drinks with various names, with various flavors. And it helps keep you awake. It doesn't necessarily enhance learning, but, and some of them enhances attention and so on. And for young kids who, physical development is important, are there nutrients that enable muscle recovery? So it becomes, a balance and actually warrants education for parents to make sure that the complement that gets on the plate is important. The issue of hunger is a whole nother thing because satisfying hunger does not necessarily satisfy the good nutrition.
So important, Patrick, 110%. Dr. Garrison, I know that you're a big nutrition guy. I mean, what's your thought on this topic?
Okay, I'll give you a personal example. One of the pillars of Islam is to fast. And when I was younger, I would fast, sun up to sundown and do surgery. I have stopped fasting on the days that I have to do surgery
Hmm.
because I'm afraid that I may make a mistake based upon my brain not functioning as sharp as it should be functioning.
Mhm.
So my nutrition is an absolute that people need to eat properly. And not just eat properly, but the timing of how they
Right,
eat
right,
is
right,
very
right, right.
important.
So agree.
You know, um, eating your biggest meal at 8 o'clock at night, although, it might be fun and sexy out and about in the restaurant and stuff, is not the best things for you.
Mhm.
Hmm.
You know, I also think that exercise is important, especially as, what did you say, Dr. Duncan? A geriatric at 65? Just as we geriatrics walk forward, that we have to have the proper nutrition. JFK just came out with an upside down pyramid.
Oh.
I think it's crazy. Um, but so we have to adequately give the proper nutrition and we must exercise. Why do we see so many falls in older people? Because they don't exercise.
Mhm.
As we get older, it should be more strength training for those
Hmm.
muscles that help us keep our
Hmm.
balance and help us
Hmm.
stand upright, as
Hmm.
opposed to aerobic. We don't need
Hmm.
to run marathons anymore.
Hmm.
We need to lift some weights, light weights. So I think that was a great question about the role of nutrition, but it has to be also coupled with physical activity as
Hmm.
well.
Hmm.
And as Dr. Duncan will probably say, tell me if I'm wrong, there was a study that said that couples that walk together live longer together because
Mhm.
Yeah, you just got to make sure you go down the lighted alley, not the dark alley, because she may get you in that dark alley, brother.
sleep with one eye open. But so I think all these things on our overall mental status,
Mhm.
and we didn't
Mhm.
even get into just normal mental status.
Mhm.
We talked about a disease process, but
Mhm.
just you have a healthy mental status on a
Mhm.
regular basis. I think nutrition, exercise, spirituality,
Mhm.
um, activities outside of what something that we can do together, something we can do apart, but something that keeps our interest, um, that we enjoy,
Mhm.
are
Mhm.
part of our overall health well-being. Dr.
Yeah.
Duncan, I'm going to take this opportunity to express my appreciation for your thoughts, your comments, your
Mhm.
knowledge, your dedication to your
Mhm.
chosen profession, and I wish you all the successes in the world. You have a bright future in front of you. Keep it up, young man.
Thank
Yeah,
you
and I
very much.
echo the same sentiments. I think, you've highlighted some things that we take for granted, right? One of which the appreciation for the generation that's coming after us, like you, because that's been one of our dilemma. We don't see brothers. We see some sisters coming through, not enough of them, but we certainly are seeing a decline in young brothers like yourself coming through. And the other piece of it is that you've highlighted that I think is so important is when I see and talk to Jordan, it may be related to a patient, but we always are looking out to, hey man, how you doing? Are
Mhm.
you all right? How's your health? The same
Yeah,
thing. Omar and I, we meet in the hallway, and sometimes all we do is talk about basketball. You
That's it.
know, how
That's
you
it.
do, just to enhance our sense of well-being, because like you said, the older you get, that social circle shrinks. If I tell you since COVID, how many of the people who were central to our well-being and central to our stupidity that we carry on with every day, as Jordan said, slapping each other on the butt, how many of them are gone?
Yeah.
It would
Yeah.
baffle your mind.
Yeah.
and
Yeah.
and
True.
and, and thanks to Dr. Williams as well for her intriguing, probing questions. That felt like she might have been leading the discussion.
Yeah.
I know, right?
Yes.
Dig it, dig it. She
Yes.
had some excellent questions coming through. I'll tell
Yeah.
you. I'll tell you. Well, the one thing I was thinking, and we were talking about seniors, is mentally, and try to stay communicated, that keep that communication that you have with as many friends as possible. Do different things, explore different things. You know what I mean? And read as much as you can. There was one thing I read an article the other day. It's like just do something as simple as just try to sit down and for 5 minutes try to think about what you did the day before. Really think, did I do this? Did I do that? I got up. What did I do after that? What did I do? Just that mental um, procedure that you go through every day and just trying to think keeps the brain, stimulated as we get older. So those are some of the things too, mentally as well as physically. You got to
Yeah, I
try to
can't
stay
forget
on
the day I
top.
rang Omar's doorbell and he answered the door with his guitar hanging around his neck. I go, oh, he's injecting some balance into his life.
I got to try to keep those fingers going,
I
man.
know.
But
No arthritis in the left fingers, please. Left
the
hand.
interesting thing was, Patrick, you were trying to come to my house, and how'd you end up at Omar's?
I know. Hey, I still forget which medication I take to help my memory, okay? So,
I hear you. I hear you. Oh, Dr. Duncan, I'm going to tell you, this has been truly, truly an amazing webinar that you've put together for us here. And the thing of it is that you've agreed to come on when you have a chance to come on, come back on it, and not as someone who's king, just as a panelist like the rest of the guys, and sit here and just give your opinion. And because we need your opinion, you know what I mean? Our mental health is so important to our community, and we need someone like you to just give us a tweak every once in a while. That little tweak goes a long way. You may think it's nothing. I said this, I said that, but that
yeah,
little phrase, that little, you know, emphasis on something that someone's having a problem with, it means worlds to them.
yeah. Plus, the optic is important, right? Because for the rest of us, we're, as you put it, approaching that geriatric part age
Well,
group.
hey,
And for
Pablo.
other people who are looking
Hey,
on to see a young person
Pablo.
coming on, the
Yeah.
optics is important. It
Hmm.
really
Yeah.
is important.
Yeah,
Yeah.
yeah. So I'm just going to tell everybody out there we're trying our best to encourage young black males to go into medicine. But yes, also when we find a standout like Dr. Duncan, we invite them to our panel as
Mhm.
well. And that's the thing. I just don't want this to be a bunch of old dudes sitting around jawing and you know what I mean. I want the young brothers to come in and give their
Yeah.
opinion as well because their opinion is going to be different because the world
Mhm.
is different. I
Mhm.
mean, literally, we have AI to deal with now.
Yeah,
And
someone
thank,
put up a AI on a slide. I thought they were talking about the steak sauce. It's just a different time.
hmm. So things are so different. So we need you young brothers to come on and give your opinions of things because that's the future. And that future is going to be here long, after these old 60 over 65-year-old guys are gone. So we need you guys. So I'm just so appreciative of you coming on, doing what you do, and I'm just so impressed with you, brother. I'm going to be very honest with you. And thank you for what you do. All right, so we're going to end this. We're going to do this thing next month. We have Dr. Cynthia Page coming on, and we're going to be talking about guess what? GLP-1s, the
Mm,
good and the bad of
okay.
GLP-1s, because
Okay.
it's not all good. And Cynthia is excellent, Dr.
Yeah.
Page. So we're going to have her here, and she's going to rock and roll. In closing, thank you for OB Healthy for letting us bring this platform to you once more. I just got to thank them all the time because without them, we just could not do this. Remember, this is every second Saturday. We're right here. We want to answer your medical questions. We will answer them to the best of our ability. All righty. Please go back and look at our past webinars. Just go to OB Healthy, hit the doctors tab, and you'll see that page and hit that little camera. All of our YouTube will come up. Just subscribe to that YouTube channel so we can continue to bring it to you. Caring and sharing. Hey, it's about caring and sharing. Tell somebody about what we doing here and come in and ask their medical questions. Most important thing I can say is please do not change any aspect of your medical care until you connect with your physician. Only your doctor can best care for you from a medical perspective. All righty. I look forward to seeing everybody who's tuned in this time next time. All righty. And all I can say is spread the word. Spread the word and let them know, let everybody know that we exist. All right. Dr. Duncan, thank you. Dr. Garrison, as usual. And hey, Patrick, I'll see you in the hospital, bro. All
All
right.
right, man.
Yes, sir. Yes, sir. Until next month, I'm going to say peace to everyone.
Yeah, Matthew, I'd love to stay in contact with you, man. Just reach out to Dr. Bay, forward some information, because Dr. Garrison could really need help. And oftentimes he look for me for to guidance, you know.
And I hear
Um,
your voices.
I mean, I got to keep him focused. I got to keep him straight. He's one of my big brother, and I love him.
All righty. All right.
I can hear
Listen, you
your
got.
voices. I see music coming out of the speakers.
All right,
All right,
everybody.
guys.
Have a good month, and we will see everyone next month. Thank you
Yes,
very
sir.
much.
All
Later.
right.
All right.
Peace
Peace,
out.
All right,
everybody.
everyone, take care.